This is my first time uh, as a presenter for the Pushpanjali Medical Center education program. And sir, I was adequately warned by my colleagues in Max Vaishali about two things. One, that you better be on time. This is not the standard CMEs which start very late. And second, they said the audience is always very receptive. And once I heard Sir's talk, so I now wonder why the audience is receptive, because the content of education seems to be very high. So, sir, Dr. Ankit Bhatia, my colleague, gave me a topic that present a unique case. So I thought that apart, there is a unique case which I am going to present, and I am going to give a slight background of why is it unique and what is the uniqueness in the case. So whenever the concept of oncology comes, one word that strikes us is chemotherapies. I mean, irrespective of the stage, irrespective, even if it's a stage 1 patient, the first thing that strikes the patients and attendant is that now we are going to be subjected to chemotherapy, and it is a word which really has emotional connotations to it. So with that, I'll bring a concept of precision medicine. What is it and how are we doing about it? So chemotherapies are part of cancer management right from stage more or less 2 onwards to stage 4. Primarily they become the backbone of the disease for stage 4. So the concept which I am trying to give is that chemotherapy is not the only thing which is there. It is now part of the management, not the only management for a stage 4 cancer. So precision medicine basically means tailorized medicine. For example, if a patient is sick, we often give augmentin, fixed dose, irrespective of weight and height. In oncology, the chemotherapy medicines are described in terms of body surface area, but that's the only precision that medicine is tailorized to. Oh, sorry. So precision medicine basically means tailorizing the treatment as per the patient's mutations. There might be a patient whose same stage, same disease. For example, there might be a stage 4 patient, breast cancer, and they may have completely different treatments. So we can't assume that the treatment is going to be same for same stage, same cancer. That's the concept of precision medicine. Why did it arise in the first place? The need for this arose because we found that in the same cohort of patient, let's presume a stage 4 patient of lung cancer or breast cancer, some patients were very good responders and some were not. And similarly, some patients were having a lot of side effects and some did not throw any side effects. So the best cohort was maximum efficacy, minimum side effects. So upon understanding how to select those cohort, that is the whole art of precision medicine. It goes by various names: biological therapies, targeted therapies, so on and so forth. So the concept behind this treatment is that we try to understand what is called as the driver mutation. So when I say a stage 4 lung cancer, it may stage 4 lung cancer adenocarcinoma. This cohort may have different driver mutation, thereby different treatment for same disease. So conventional therapies like this, we try to open the door with a hammer. It is effective, but it has its own side effects. Precision medicine is like opening the door with the key. If we know the driver mutation, we are much more successful and with much less side effects. If so this is the case which I am going to present today, that how we are managing the case. So traditionally, breast cancer treatment, we all know, goes by TNM staging, and we often ask what is TNM and what is the stage. Then of course we go up to grade, and then if some of you may know, we also ask ER, PR, HER2/neu. They are the hormonal status. Now ER, PR, HER2/neu means we are trying to do a precision on ki same patient hai, kisi mein different combinations can happen. But how the things are changing. So these are the driver pathways. Now the same patient who may be HER2 positive, or let's say a triple negative patient, may have different driver pathways, and these are the driver pathways we try to understand and try to block in a same set of patients. So now the information becomes stage, grade, ER/PR, HER2 and what was the driver mutation pathway. So how do we do that? Of course, the protein expression, which is the ER/PR, HER2, etc., are known by immunohistochemistry test, which the pathologist does. But there are other set of tests. FISH test, we all know. There is something which a lot of you might have heard, a lot of you might not have heard, is something called as a NGS testing. NGS means a next generation sequencing, which basically subjects the tumor to various assays, and we try to understand the DNA mutation, the RNA mutation, and the phenotypic expression, which is the protein expression. So these three are, the data is compiled, and we try to understand what was the driver mutation which is causing the disease. And then there are various AI based algorithms which try to get to the root cause of that driver mutation. Of course, the same thing if done on blood is called as liquid biopsies. I won't go into the detail for the paucity of time. So drugs, various pathways have various drugs. So this is the kind of thing I was trying to tell you. Precision medicine means a phenotypic expression of breast cancer can have different pathways, so different drug is there. So now I come to the case. This is a 80-year-old lady. She stays in Greater Noida. She is my patient, and a typical family whose children live abroad. She was a retired principal, and she doesn't have any comorbidities, and her husband is also active. He was 84 when this disease was diagnosed. So she was diagnosed with breast cancer stage 4, and she had lung mets. And she was diagnosed with an aggressive variant which is called as TNBC. TNBC means triple negative breast cancer. That means ER/PR, HER2/neu. So the only HER2/neu was negative. So the only active treatment possible for this patient was chemotherapy. Now, specific issues to her were: number 1, stage 4 disease; number 2, 84 years of age; number 3, limited family support; number 4, husband also was fit but not fit to take care of her in the sense a chemotherapy patient requires. So all in all, the patient required chemotherapy but refused because of various logistic supports apart from her age. So again, we took the sample and we subjected it to a NGS test. Now NGS are of various types. We subjected them to, let's say, one of the NGS tests, and what we found was that she had a particular mutation for which immunotherapy was supposed to be active. So she had something called as CPS, combined positivity score, which was very high, and we gave her immunotherapy and she responded. So these are not anecdotal cases. It's not a rare case. It's one of the run-of-the-mill cases whereby we are now able to manage treatments without chemotherapy. So my first message was that chemotherapy gives a psychological shiver. We are getting into that era where we can minimize the use of chemotherapy. So see, these are 4 images serially done. We can see after just 1 infusion, the inflammation of the surface has reduced, and after 3, the breast has become soft. Similarly, she responded in chest nodules also. So much so that she maintains to be on, the drug is called as pembrolizumab. MAB means, MAB means monoclonal antibody. ZU means ZU means some part has been taken from animal, and that is the nomenclature. So she was on this drug and she responded. So what really happened? We were, in this case, it's not that we are able to do that in every case. In this case, we were able to find a driver mutation, we were able to find the cause, and so we just unblocked that driver mutation and she responded. A little bit about how does immunotherapy work. Now, immunotherapy is one of the many targeted therapies. The pathways which I showed, immunotherapy works on one of them. We can have so many other drugs. So this was a funny cartoon which I thought will drive home the message that how does the immunotherapy work. Now assume that a cancer cell or a tumor cell is like a thief. Now we all make cancer cells in our body daily. Our immune cells are supposed to kill those cancer cells. This is a normal human being, normal human physiology. What happens in a cancer environment if the CPS score is high? If the CPS score is high, then the thief, the cancer cell, bribes the policeman, which is the immune cell, and immune cell doesn't recognize the tumor cell as a foreign body. So this is what happens. Our immunity doesn't recognize the tumor cell uh, 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 as a foreign cell and doesn't kill it. And how do we know that? We know that by the expression of that one protein which I called as CPS. So immunotherapy is a very generic term. Actual term is checkpoint inhibitors. So checkpoint inhibitors basically break this nexus. For this very thing, um, uh, the Nobel Prize for Medicine was awarded to the two doctors who had discovered this mechanism. They had discovered it in 1992. The Nobel Prize was awarded in 2018. So this was just one example. One example of one pathway blocked. So the more pathways we come to know, the more blocking we can do. So the art lies in knowing the pathways and developing a drug. So this has translated into better overall survivals. Things are changing. The idea is that if somehow we can make cancer something like a chronic disease like diabetes, that the patient is able to live with it. Another example you may all know is CML. Now CML was invariably fatal somewhere around late 90s and early 2000s. Then we got to know about the BCR-ABL pathway. Now all the CML patient takes is one tablet, imatinib, and now we have others, dasatinib and so on and so forth. We all know that the treatment of CML is simpler than diabetes. The treatment of CA lung, sir, so many times we give just one tablet. He's taking more tablets for diabetes and hypertension rather than for CA lung. So of course it's a teamwork. This is just the breast cancer management team. They all come down to focus on that one patient for better outcomes. And the outcomes are, this is our breast cancer survival group. This is how it is for so many other survival groups. With that, I conclude, sir. Thank you for a very patient listening. Thank you.
Sir, how expensive is this therapy for a patient who is already financially depleted?
Yes.
What do you think? What is the financial?
So I will tell you, sir. Of course, I can tell you about so many drugs. I will tell you about the one which we did, pembrolizumab. Now, first I will tell you at what cost it was launched. One injection was 4 lakh rupees, and every 3 weekly. So, if a patient survives for 1 year, the cost is 72 lakh rupees. Now, this is out of pocket for anybody. Now, what Government of India has done? They have launched a program called as Kiran program. If the patient has a earning less than 25 lakh rupees per annum, the cost, that is 72 lakh, comes down to 10 lakhs. So the patient has to buy one injection at half the cost, which is 2 lakh rupees, and 5 injections he has to take. Rest of the therapy is free. This is under Kiran program. Now there are various programs which Government of India is running. So if I were to put a ballpark figure for, let's say a patient comes to me, what do I say to him? I say that, look, if we give a chemotherapy, rough estimate is about 2 to 3 lakhs for a 4-month therapy treatment. And if you are eligible for immuno, then your treatment cost is 10 lakh rupees a year, which is fixed. What I have seen sitting in Max Vaishali, which is Ghaziabad, that 50% patients understand and they take this. So while you may debate that 10 lakh rupees is too much, but I presume the kind of socio-economic strata we are sitting in, at least 50% patients are able to manage, because everybody more or less has some 2 to 5 lakh rupee insurance. So it is manageable. It is not that 72 lakh thing by which it started. Now this is part one of the story. Part two is our companies are coming up with generics. The moment these generic comes, the cost becomes less than, what should I say, 1/4. तो वो भी चल रहा है. The only problem is Indian government has now signed that WTO agreement. Under that, we will be arm twisted. I'll give you one example of arm twisting. There was, so drugs का क्या होता है सर, दो टाइप के पेटेंट होते हैं, एक ड्रग पेटेंट, एक प्रोसेस पेटेंट. सो ड्रग पेटेंट 10 years होता है. एक देयर वाज वन कंपनी, आई वोंट नेम, जब उसके 10 year पूरे होने लगे, उसने क्या किया, 10 पेटेंट उसी ड्रग पे और डाल दिए, प्रोसेस पेटेंट्स. नाउ यू कांट मेक इट, एंड वी हैव साइंड, इफ वी साइन द WTO विच वी आर बीइंग कॉर्नर्ड, फिर ये जेनरिक वाला प्रॉब्लम आएगा. अदरवाइज अभी तो आवर्स इंटास, जाइडस, ऑल दीज कंपनीज, I don't know how they are managing, but they come up with a generic within 4-5 years. सर मैंने वो दिखाया था ना, वो मैंने एक स्कैन दिखाया था, उसमें वो मेट्स का भी वो ग्राफ था, वो सारे के सारे डिसअपियर हो गए थे. व्हेन आई से डिसअपियर, दे आर, इट डजंट मीन क्योर. इट मीन्स अब होगा क्या सर इस पेशेंट में, ये पेशेंट में 6 महीने से लेके 1.5 साल तक ये दवाई काम करेगी, फिर ये प्रोग्रेशन हो जाएगा. Now why the progression happens? This progression happens because there are parallel pathways. वो ड्राइवर म्यूटेशन के जो pathways थे, कोई ना कोई नया pathway बन जाएगा. Body tries to escape. How does the cat and mouse game go? फिर कोई और दवाई म्यूटेशन दे देंगे. पेशेंट को लगता है कि ये लोग ना बस दवाई पे दवाई दिए जा रहे हैं. There is a conspiracy theory के कैंसर का तो इलाज मिल गया, ये छुपा के बैठे हुए हैं. But the reality is mutations change and so does the treatment. हाँ, yes, yes, yes. 35 drugs, most of them are oncology drugs. उस पे कस्टम ड्यूटी वेव ऑफ हुई तो 20% तक का कॉस्ट रिडक्शन है. राइट, दैट्स सर 80% yes, 20% में ना ये लोग, there is a cheating going on. They somehow show there is something called as a sub limit. Now you may have a insurance of 20 lakh rupees which will adequately cover your treatment. Sometimes sub insurances, usually star insurance सबसे ज़्यादा इसमें आगे है, ये उसमें जब उसमें एक जगह सब लिमिट लिखी होती है, सब लिमिट 2.5 लाख, तो बाकी 18 लाख में एंटीबायोटिक्स कवर करके कोई भी किसी भी, सो इस पे स्कैम चल रहा है. मेरा बिलीफ ये है सर कि ये इंश्योरेंस सेक्टर, जैसे सर ने अभी प्रेजेंटेशन किया, ये violence against doctors, there is, it's even insurance is very murky. It needs more stronger ombudsmen and more clearances. They try to reject it, but 80% they are covered.
But any answer was given to the insurance companies in US on Big Shot was murdered. The CEO was murdered. By the way, Mankind is coming up with a generic version of Keytruda, Oncology.
जाइडस भी ला रही है, हाँ जाइडस भी ला रही है सर. थैंक यू सर.